Hi everyone, this is Mr Neel Raithatha, also known as the Wax Whisperer. Thank you for joining me in my latest video. This patient originally attended 7 or 8 months ago, and in fact, if you visit episode number 779, I will put a link of the video in the description tab. You will see their original appointment, and on that occasion, they were suffering from an ear infection. It was active, it was all discharging the ear, and they had a double perforation of the eardrum. So they had 2 holes of their eardrum, and as such, once we cleared all the debris, I referred the patient to their GP, and they needed some non-ototoxic medication. So a lot of the antibiotics provided for ear infections, they are what we call ototoxic. They're a group of medications. They're under the umbrella term or the classification of aminoglycosides. And these medications typically end in mycin. So, for example, streptomycin, erythromycin, neomycin, gentamicin, to name but a few. And if these ototoxic medications enter the middle and inner ear via the eardrum, so if there's a hole in the eardrum, for example, or there's a grommet, they sometimes can lead to a permanent hearing loss. And for that reason, the patient needed a special type of medication, ciprofloxacin. And these drops are non-ototoxic, so they can be used within the ear if there's a perforation. These medications were typically used for eye infections, and originally they were used off-label by doctors and ENT for ear infections. However, the manufacturers of the drug now manufacture it specifically for ear infections. So at the present time, we can't see the hole in the eardrum. Now, the patient is still awaiting an ENT referral, believe it or not. The referral's been made, but they're waiting for the appointment, and it's been 7 or 8 months I mentioned. So episode 779. And they were experiencing excruciating pain in this ear, and they went to the doctor first because they thought it was an ear infection. The doctor did prescribe some medication, some painkillers, but they weren't able to visualise the eardrum because of all this dead skin. Now, this dead skin was causing the patient the earache. It wasn't the hole in the eardrum. There was no active infection per se. This skin, it was so sharp, like shards of glass, and it was very difficult to remove. As soon as I made contact with it, it was so rough-edged, you see. As soon as I made contact with it, the patient could feel it abrade and rub against the ear canal. It was really difficult. Ideally, you would like to soften this dead skin. So with dead skin, I generally instill sodium bicarbonate earwax drops. However, because of the perforation, we just wanted to keep, well, I weren't sure whether there's still a perforation, there's a slim chance that it's healed, but I just didn't know what was going on behind this. And for that reason, I resisted to use sodium bicarbonate drops. Now, I was speaking to a good friend and colleague of mine who's an ENT surgeon today, just about certain medications, or not medications, but drops, and the efficacy and safety if there's a hole in the eardrum or grommet or T-tube. And we had a discussion, and it's always tricky. You want to keep the ear completely dry, but if anything, sodium bicarbonate drops is probably a bit better than olive oil drops. Sodium bicarbonate is actually found in our bloodstream, so it's probably safer to enter in the middle ear than olive oil, for example. But so I had to use some drops earlier today on a patient who's got T-tube, and they had some. They come on a regular basis, every 3 or 4 weeks actually, and they experience the most severe itchy dry ears, and they've seen the ENT, and there's nothing much more that can be done apart from regularly cleaning their ear of dead skin. And where the T-tube is on the eardrum, the skin that migrates of the eardrum is getting trapped around this T-tube, and it's settling on the eardrum, and the patient had a really thick crust of dead skin. In the past, I've managed to remove it. I will try and upload that video this week later on. But on this occasion, the skin was just too adhered, too dry, too thick. So I had to put a bit of sodium bicarbonate drops. But when I put it in the ear, I was very careful because I had the patient's head tilted across, and the T-tube is more anterior, is more to the left-hand side. And this dead skin, it was a bit more, it wasn't inferior, it wasn't at the bottom of the eardrum, it was a bit higher up. Whereas this dead skin, fortunately, is more inferiorly and posteriorly, so there's the back and to the right, the opposite direction of the chi tube. And I tilted the patient's head in such a way that when I got the dropper bottle and I put the sodium bicarbonate drops in, I was just putting enough, I didn't overfill it, just so it was sitting on the dead skin, but not, it wasn't going to go through the T tube. And we soaked it for a few minutes, and I've managed to remove that skin without any of those sodium bicarbonate drops entering the grommet. If they do get into the middle ear, sodium bicarbonate drops, it can sting. So just going to be really, really careful. So we're just making headway here, and we can see a bit of the eardrum. I still can't see the perforation at the moment, so I don't know whether it's healed. But again, I'm trying to, you can just see how stiff and how adhered this skin is on the back part of the ear canal. And the patient, again, was finding this a bit uncomfortable. But we just needed to remove this, and the patient was happy for me to continue, because I'm just being very gentle. I'm trying to avoid contact with the canal wall. So the eardrum is now visible. So I'm just working on the back bit. Now this piece in particular was very uncomfortable for the patient. You could, I don't have the audio on, but when I made contact with the skin, it made a tapping noise. It was like a coin dropping. It was a really loud thud, and that's how it was pinging. That's the word I was thinking of. It made a ping, and you can just see how crusty and sharp that side, the edges are. It was really, really sharp, and every time I was moving that, the patient was rubbing against the canal wall, and it was, as I said, a bit uncomfortable for the patient, but they're happy for me to continue. You can see in the background, that's actually adhered to the eardrum. I'm just peeling it off the drum now. Again, I still can't see the perforation, because that part, the patient just flinched a bit. So I'm going to go back in, and I just preempted the patient, so we're just going to use some forceps now. I'm just going to pinch and pull and get this out if I can. So I'm just trying to get the jaws either side, and you can see how I went there. I just grabbed it and came away very quickly. So I believe now this is off the eardrum, but I still got to manoeuvre this crusted skin away. I'm just using the fine end suction probe here, and that's because sometimes with skin it can clarinet. The skin violently flaps at the tip of the sucker, and it emits a very loud high frequency squeal. It's quite noisy for me actually as well, not only for the patient but for the clinical ear care specialist as well. But I'm going to go back in with a full sucker in a moment, the full Zollner sucker for more suction powers. I need that to remove this. I think this is the moment. Yeah, this is the bigger sucker. The standard sucker, should I say. And I'm just moving that upwards. You see those little wriggle motions I'm using as well, just to help detach the skin. That came out in a big plug. So this has got some there, that's obscuring the view. Let's remove this. Now, it's very interesting when you see this patient's eardrum. I can actually see, and I believe it's the umbo region of the hammer bone. It was visible. The bone was exposed through the eardrum. And you'll see it in a moment. Now, the umbo, so the hammer bone, also known as the malleus, what's visible to us? So there's the perforation, and just at 9 o'clock there, you can see some of the bone, and I think that's extending from the hammer bone. We call that region the umbo. It could also be part of the long process of the incus. It's very hard to tell. The endoscope's just there. I don't want to go any further with that, but you can see I'm just at the entry of that eardrum, so almost like we're going through the eardrum there. So the hammer bone, typically there's three parts that are visible, and we have the long arm of the hammer bone. We call that the manubrium, and then in the middle of the eardrum, you can normally see the umbo of the hammer bone. So that's the bottom part of the hammer bone that extends into the centre part of the eardrum. And that's normally attached to the eardrum in the middle, almost like a bullseye. And I think that's what that part is there. And I think it's almost detached itself, because of the perforation, it's detached itself from the eardrum, the umbo, but that bone will normally stick to the underside of the eardrum. And then at the top of the hammer bone, you see like a little pointy ball end, like a pinhead, and we call that the lateral or short process. And there is other parts to the hammer bone. You get the anterior part, the anterior process, as we call it, and you get the neck of the malleus. So, and and you get the head of the malleus. So I hope you enjoyed that video, guys, and you found it interesting. And interestingly, that perforation is now one singular perforation as opposed to a double one. Take care.